session ran over. Hopefully this won't. All right, so welcome to the APAO, AAO, SAO joint symposium. The title of the symposium is What's New in 2024, should be 25, in ophthalmic research. Dr. Paul Chan is not going to be here, so he let us know. And Dr. Radhika, she should be here, she's not here. And I'm Vishal Janji, I'm from the University of Pittsburgh. Without further ado, I'm going to invite our first speaker, Dr. Virendra Sangwan. He's going to tell us about stem cell solutions for corneal transplantation. Thank you, Dr. Sangwan.
It's my pleasure to be here. I'll be talking about corneal regeneration using stem cell based approaches. I have no commercial interest to declare. Straightway, I like to present this young lady from Nepal who lives in Australia, had bilateral VKC and developed LS, limbal stem cell deficiency over a period of time. And this is how her eye, one of the cornea looked like. This is her other cornea. And she's been managing with the Boston Prose lens or the scleral lens, but now even that is not working. So this is her situation. She's quite active and working. So we did a allo slat, taking the tissue from the brother, and then the surgery was done in one eye. This allo slat is a way of doing a technique of doing simple stem cell transplantation, and she received full dose immunosuppression. The full dose immunosuppression consists of 3 drugs: oral cyclosporin, azathioprine, and oral steroids. So 2 weeks later, she develops unaided acuity of 624 and improving to 6.9. And few days later, I did the other eye also. So 6 weeks later, she is 6.6 part in one eye and 6.18 unaided, 6.9 with Boston scleral lens. And she continues to be on systemic medications, well maintained, and she sends a report from Australia. This is the almost 20-year follow of a patient who underwent a similar procedure but cultivated limbal epithelial transplantation in 2001 with a very similar systemic immunosuppression protocol. So, cornea is very susceptible to trauma, and all kinds of pathologies affecting the epithelium, the stroma, or endothelium. So I'll talk very briefly about each of the layer, what is in the regenerative space. This is a patient in which we did a simple limbal epithelial transplant, had some scarring, and he didn't want further surgeries, so he wanted to wait. He used to come every 6 months to 1 year, and over a period of time, you can see there is improvement in the vision. The question is why? And we postulated that is probably the mesenchymal cells in the limbal explants are the one which are helping this particular cornea. Based on that idea, one of my fellow at that time, and now is a full-fledged faculty and an active researcher, Sayan Basu, he did a work with Professor Fundenberg in University of Pittsburgh, and they figured out that yes, the mesenchymal cells are very important, and Professor Fundenberg had a very long history of working on the mesenchymal cells and figured out the clinical translation for them. And science simply replicated that model in a mice in Pittsburgh, and they published this result. So when you look at the therapeutic benefits of mesenchymal cells, they are very important, they are multipotent, or they have different kinds of effects in different situations. There is a very good active researcher in Harvard. His name is Sunil Chauhan. He has been working on the idea of mesenchymal cells for chemical injuries in the rabbit model and the mice model. He has figured out that it's the HGF, the hepatocyte growth factor, which is the key ingredient in mesenchymal cells. And based on that idea, they have started a company called Claris Bio, which is doing a clinical trial in the use of HGF in treatment of the neurotrophic keratitis. And similar kind of work Sayan and his group are doing in an LVP, treating the different kind of pathologies with mesenchymal cells, and this is now FDI, this is DCGI approved. This is the example here. And I think there can be variety of applications for mesenchymal cells, chemical burns or Moran's ulcer or VKC. So I see these potential applications. There's another interesting application that we are using. The exosomes derived from the mesenchymal cells are being used to develop a liquid cornea called Curogenics, along with Pandorum, a startup company based in Bangalore. And this is a animal or rabbit model in which we have tried this treatment. The endothelial regeneration is led by Professor Kinosita, and I was recently 2 months back in his city in Kyoto. They are doing this treatment for a long time, and now it is commercialized in Japan along with the Japanese government and a company called Orion Biotech. And this Orion Biotech is now purchased by Alcon. Just morning only Professor Kinosita told me that this company is bought by Alcon in all stocks deal. So it looks like there is a moment of increasingly there is a commercialization of regenerative treatments. And this is a short video of the SLAT. I very quickly run through that these are 3-year result. This is 12-year outcome of a patient who underwent SLAT. So this is very, very stable. Similar, another patient of 12-year follow-up. And if you look at confocal microscopy, 10 years later, you can make out that operated and unoperated eye hardly any difference. Similar is the subbasal nerve plexus. And these are, further innovations in SLAT. In Russia, they have been able to do SLAT without glue and without amniotic membrane. And this is pioneered by Professor Boris Malugin. And he's even using femtolaser for doing SLAT. Very interesting. And I'm very excited that he's further refined. There's one Dr. Jain and Dr. Mittal. They think, and they are reporting use of SLAT without amniotic membrane, which means that you can further reduce the cost, and it can really penetrate in the societies where the surgery is needed the most. And these are some of the other, comparative study by Namarta. And when you look at the cost, it is a very, very cost-effective treatment. We have published in BJO in 2023 about the cost-effectiveness of this treatment. So in summary, the SLAT is a very effective, replicable, repeatable procedure utilizing the stem cells and a surgical technique, and it allows the corneal epithelial regeneration, and it's very, very stable treatment. Thank you very much.
Thank you, Dr. Sangwan. Any questions from the
Yes, Vishal, if I can answer any question, because I have to run to another session.
Yes. So that was a very interesting talk. I have only one question. So what do you think is the biggest barrier? Because you see most of the innovations are coming from the Asia-Pacific region, which is great. And United States is still lagging behind. What do you think is the biggest barrier to sort of development of these regenerative therapies?
I think it's the mostly regulatory hurdles. Amount of time it takes, the regulation, there can be a scientist fatigue, there can be a loss of interest, there may be some people retire and they lose interest. So amount of time or years it takes for regulators to approve, it is very, especially if it is a cell-based therapy.
Yeah, and I completely agree, having worked in a few parts of the world and now in the US, it is definitely the regulatory bodies that sort of push us behind by a few years. I also think lack of active collaboration between institutes, that's also another hurdle.
Yes, that's another.
That's really important.
If we have big collaborations or big institutes collaborating together, that problem may be reduced a little bit.
Yeah. Thank you so much.
Thank you.
All right, well, let's move on. Our next speaker is Dr. John Campbell. The topic is AI revolution in ophthalmology.
Thank you very much. Thanks for the opportunity to be here. I have the privilege of chairing the American Academy of Ophthalmology AI Committee, which I think is why I'm here. Do you have my slides? I did, yeah. If not, maybe we should switch and I can come back.
Yeah, just give them a minute.
Sure.
We have enough time, I think.
Okay.
Do you have them on a computer?
I do.
Okay. You have your laptop on you right now?
Yep.
I think they did it on purpose. This is a presentation on AI, so that was a good plan. Thanks.
All right, there we go. Again, thanks for the opportunity to be here. I was asked to speak about AI in what's new in ophthalmic research, and obviously there's a lot of things I could try and cover in this session. These are my disclosures. They aren't really relevant to what I'll be talking about. So clearly AI is a hot topic in all of medicine, but in particular in ophthalmology and eye care. This is what I'll try and cover in the next sort of 9 minutes or so. A little bit of background on why it's an important topic, but I think everyone knows that. A little bit about where AI started in terms of image analysis and the applications. I'll touch on the new hot topic of oculomics a little bit. Talk a little bit about what everyone's talking about, which is generative AI and all the different applications. And then I'll leave with a little bit of a pessimistic note, which is on challenges and implementation for these technologies. So as background, I think what motivates all of us as eye care professionals is that the prevalence of pretty much every major cause of blindness is increasing as a result of aging populations worldwide. And there simply aren't enough eye care providers for the traditional model to deal with that. AI in ophthalmology has been an increasing topic, number of publications going up exponentially over the last 15 years or so. We're all familiar with the idea that AI can look at an image and make a medical diagnosis. Pretty much at this point, if you have enough images of anything, you can train a computer to diagnose or label that image as well as a person or physician can. But I'll talk about a number of other applications of that. One is that a topic we don't often think about, which is two physicians, because much of eye care, much of ophthalmology is subjective and qualitative, 2 plus nuclear sclerosis, 1 plus nuclear sclerosis. Two doctors can look at the same patient or the same image and come up with different answers. And AI can help with that. It can help create objective outputs for diagnosis to improve standardization. And here I'm just showing this classic illustration. Two people can look at the same object and come up with 3 answers. An AI, you put this into ChatGPT and it says, oh yes, this is a classic paradox. And there's a number of applications I think we'll see of how AI can help improve clinicians. So it's not AI versus clinicians, AI plus clinician leading to better outcomes. We're also all familiar with the idea of using AI in place of a physician at the point of care. In the US, there's now 3 autonomous AI algorithms for diabetic retinopathy. If you think about a lot of these problems like diabetic retinopathy or ROP worldwide, it seems like one of these unsolvable problems where just there aren't enough physicians to deal with all the starfish, to use the analogy of starfish washed up on a beach. One way to address that is, I always try to remember primary prevention, improving access to care. So improving primary prevention reduces the number of people with disease. But autonomous AI can help expand the reach of ophthalmologists, make it more efficient. And I think that hopefully we will see better implementation of this to lead to improved outcomes worldwide. The other main application, which I think of as using AI sort of under the hood, is how AI-assisted imaging can actually be better than our eye exam. We all know this, but all of these algorithms use AI underlying it to help improve image quality and actually visualize things like cystoid macular edema on the left or CNV in the middle better than we can just on our own. And so AI is going to make us better, more objective, and more sensitive examiners. Moving on to oculomics, this idea that you can look in the back of the eye and learn something about the systemic health is not a new idea. I mean, we've known from all of our training that you can diagnose diabetes, essentially, even if someone doesn't know they have it, or high blood pressure, or papilledema reflects systemic diseases. Oculomics simply takes that further to move beyond what we knew we were capable of doing to be able to diagnose other things. So this is from a recent review, identifying all the different organ systems that theoretically have manifestations in the eye or in the retina, that with fundus photography or with OCT, you can train algorithms to predict the presence of these conditions. I think the two main questions remain, is it better than the existing care models in terms of predicting any of these things? And second is, how do you incorporate this into the patient care pathway in a way that makes a meaningful impact to patients? Generative AI is a hot topic, and it has a lot of different applications, one of which is the creation of synthetic images. Using a number of different models, such as a GAN, generative adversarial network, you can create images that are as realistic as real images for a number of different applications. I think the two main applications here are for creating larger data sets for AI training. You can create a data set of entirely synthetic images to supplement or replace the need for authentic images for AI training. And we and others have demonstrated that you can create a fully synthetic data set and train algorithms that work as well as if it was trained on real data. The other potential benefit of this is for education. Given that there's challenges around data sharing, you can create and educate using entirely synthetic data, which gets around some of these issues. There's also a number of different networks that can take an image and modify it to take an image, for example, of a baby with no ROP and convert that same image to having ROP. And then I think the elephant in the room is all of the implications of large language models that are coming, and there's no possible way to summarize this in the talk. But to make an illustration, on the plane ride here, I asked ChatGPT, do you think it's safe to rely on ChatGPT for patient care-related questions in ophthalmology? And it said, that's a thoughtful and important question, and here's what it came up with. And I'd encourage everyone to play around with these models and sort of see how you feel that it can help you improve your practice and improve your career. ChatGPT doesn't think it should be used at this point for real-time patient care for a number of different reasons. And perhaps the most important is that the last two here is that these models can hallucinate, so they can give you very factual-looking information that's completely false, including making up entire references from the database that says, it'll give you an author, it'll give you a journal, it'll give you a page number, but when you actually go back and look, it's completely made up. And the last is, we've discussed in the first talk regulatory challenges, and these definitely are affecting implementation in ophthalmology, but they also have a really important role. And so we have to balance that, because all of these technologies have potential harm. And so the regulatory bodies do play an important role in trying to prevent that. So what does the future hold? Well, AI is more than just image analysis. It can combine that with LLM to take a patient history with more time and accuracy than I'm going to have at the chair side. It can review all of the entire medical record way faster than I would ever be able to do. And it's essentially make a Dr. House. This is a US television character who's one of these diagnostic whizzes. And the idea is that with this technology and combined with our own clinical skills, it's going to make us better than we are on our own. And so the last challenge I'll leave you with is, all of these papers, there's been a lot of talk on how ophthalmology is leading or was leading in this space, but unfortunately, it's not. In 2025 or late 2024, despite all the papers, there have been only 6 companies obtaining FDA clearance for software as medical device in the US. Here's a quote from Mike Abramoff. Years ago, I had a vision of the impact AI would have on healthcare, but quickly found out that vision validation and commercial adoption are very different things. And so I think this is the biggest area we need research in, is how you move from an idea that that an AI algorithm could reduce blindness to have it being impacted on a population level. And I'll just refer you, this is a paper that we wrote as part of the AI task force. It's in TVST summarizing this topic. In summary, AI is a tool. If used properly, it has incredible potential to transform ophthalmology. If used improperly, it can cause harm, just like doctors. But use requires not just efficacy, but effective implementation. Thanks so much.
Thank you, Dr. Campbell. That was really nice. Any questions from the audience?
That was a very nice talk. Can you just tell us something about the current status or maybe the role of predictive AI in ophthalmology?
So the question is the role of predictive AI in ophthalmology. You're talking about like risk of future disease or something like that. Yeah. So there are a number of different applications, and we can talk later offline. We know that you can take an image and predict future disease worsening of diabetes, for example. You can take OCT and predict exudation, conversion to exudation. There's a lot of evidence that these algorithms, in particular combined with the clinical demographics and history, can predict future disease states. There's two challenges, implementation, and the biggest is these become medical devices once they act on images, and so they end up having to go through the regulatory process. And so we have to think through, and as a field, we have to think through how much value there is in that, and is there going to be a mechanism to get these algorithms approved in a way that's commercially viable. So I think there's a lot of research suggesting that, and that's one of those areas where the disconnect between research and implementation is pretty big.
I agree. I think the predictive AI is where probably radiology is leading the field right now. You know, one of the few initial papers on predictive AI were actually on radiology and, you know, prognostication and prediction of any lesions that are potentially cancerous as well. Any other questions from the audience? Anyone in the room who uses ChatGPT in the clinic on a regular basis for anything? You do? Can you tell us what you use it for? Can you please use the mic?
ChatGPT for write-ups and stuff. We just write a few points, which will probably my speech or a letter to be written. Somebody, ChatGPT regularly we are using.
So not really for diagnostics.
Not for diagnosis.
Okay. All right. Well, that's interesting. As you know, if you talk to somebody in Google, they'll tell you that the ChatGPT is as good as going to be. If you are good LLM engineers, that's what they call them. The ChatGPT and other similar LLM models and platforms are going to be great in future.
Well, if you talk to Google, they'll tell you Gemini is better than ChatGPT.
Of course,
but, you know.
yes. All right. Okay, well, thanks so much. That was interesting. We'll move on to the next topic, stem cell therapy in ophthalmology, and the speaker is Dr. Rajani Bhattu. Thank you.
Yes, thank you so much. Good afternoon, everyone, and thank you for this, invitation for this wonderful symposium. While the title says stem cell therapy in ophthalmology, I'm going to literally restrict myself to stem cell therapy in retina and what we do. So most diseases, IRDs and dry AMD and so on have no treatment, and that's one of the reasons why I'm here. The burden of these diseases is quite large, in India and the Asia-Pac region. And so if you look at the treatment, aspects, those that are mutation-specific are, gene therapy and so on, whereas, optogenetics and cell therapy, and in fact, the newest, the kid on the block, Neuralink, is all going to be mutation, agnostic. For a long time, embryonic stem cells were used in, stem cell research. So when Professor Shinya Yamanaka showed that you could actually create stem cells from peripheral blood or a skin tag, and these are called induced pluripotent stem cells. It changed the world of stem cell research, and most of us use iPSC as they are called today in research. So I want to use the next few slides to talk about, my journey with iStem. So iStem is a stem cell-based startup based out of Bangalore. We started with the specific idea of treating retinal diseases. So while the eventual idea is to look at IRDs, we've started with using iPSC-derived RPE cells for dry AMD or geographic atrophy specifically. So the previous speaker spoke about the timeline it takes from a proof of concept to literally commercialization, it can take anywhere up from 15 to 20 years. And we were talking about the reasons why it's hard to continue for 20 years. Clearly, 20 years is a very long time to withstand research to go to commercialization. So this is what the entire overview of how the lab work happens. It literally mirrors what happens in the human eye. And we start with iPSCs, and by the time we come to this set of mature RPE cells, this is about a 120-day protocol. And I'm just going to spend just a couple of slides on what happens in the lab. Once we have the cells, we've got to make sure that they are indeed RPE cells. They are the same neuroectodermal lineage. So immunohistochemistry is used a lot in ensuring this. So we've got to make sure that these are mature RPE cells. They're secretory. You have a pure population of cells. And then you look at the genomics of the RPE cells, and then whether they are functional RPE cells, before we say that here we have a protocol that we can go into GMP manufacture. So while I sort of show this in 5 slides, this has taken us about 5 to 6 years to get to the point of saying we actually have a GMP product. And so once you have the initial lab results out, the next step is to look at small animals. So we were talking about collaborations. So most of our small animal studies happen at KCI Institute in Portland, and we use the RCS rat as the model. The RCS rat has a MERTK mutation, so it sort of loses the RPE first and then the photoreceptors, and therefore is a good model both for AMD and IRDs. So the cell transplantation in these animals is not like the human eye. It's about 1/4 the human eye. So it's a blind procedure. It's a transscleral injection of the cells that happens. And so we actually showed a significant results in terms of the functional improvement, the structural improvement. So that's one of the fundus photos in a rat. So there is no macula here, so you sort of inject them either superiorly or temporally. And you use the outer nuclear layer as a surrogate marker for, to show that your RP cells are functional. This is the overall summary of all the studies that have happened since 2017. So we had to show also, in addition to all of that, I said we had to show that the cells are safe. You got to do tumor studies. You got to do toxicology studies. So the toxicology studies we actually conducted at Dabur Research Foundation, near Delhi, and once all of this was done, the next big problem we had to solve was how do we actually deliver these cells into the retina? Because some of the studies that have been done earlier have shown that the reflux of cells that happens when we inject this is a major problem. It can create large ERMs to the extent where you may need to go back and remove the ERM and so on. So we decided to go to Singapore Eye Research Institute to look at these, to understand how we actually can do these surgeries. So several surgeries done to understand, do we create a bleb directly? Do we inject BS and then inject the cells? Is there a way to reduce the reflux using PFCL? Several surgeries done to understand what is the ideal way. So this is the overview, and then once we had all of this, this is the entire regulatory roadmap that you have to go through, including your validations, your CMC, your chemistry manufacturing. So there is a lot between once you have the lab, the animals, before you actually go into the clinic. So once we had all of that, we went to the DCGI, and we applied for phase 1, an IND application, investigative new drug application. And we got the approval for our phase 1 studies on April 1st of last year. So we then started our phase 1 trials. So phase 1 trials are typically always safety studies. You got to make sure that, so you pick patients with very advanced disease, and you show that what you're injecting is not creating any harm. So do no harm is the byline for phase 1 studies. So we have a traditional 3+3 design. So 3 patients each with 100,000, 200,000, and 300,000 dose, conducted across 3 sites in India. LV Prasad Eye Institute in Hyderabad, All Indian Institute of Medical Sciences, and RP Medical Center in Delhi, and Ganapati Netralaya in Jalna. So the 3 centers with 9 patients overall. Of course, very strict inclusion-exclusion criteria. Like I said, because we need to pick patients with advanced disease, the vision in the study eye had to be less than 2200. And we also had strict GA lesion size that we had. So those are the most important for the inclusion criteria. And of course, a whole host of exclusion criteria to make sure that, you don't cause any harm to the patient. So these are allogenic cells. These are not, autologous cells. So that means our initial group of cells was from iPSC, so these are allogenic cells, and therefore the patients require systemic immune suppression. So we've used 2 systemic immunosuppressions. One is tacrolimus, other is MMF, tacrolimus for about 6 weeks, and MMF for about 3 months following the surgery. A lot of debate has gone on about the primary and secondary endpoints if you look at across clinical trials. So fundus autofluorescence and the safety endpoints, because the safety trial, these were the primary endpoints. And your BCVA, your fundus photo, OCT, microperimetry, and the NEIVFQ were our secondary endpoints. If you look at the results, so that's just one of the surgeries. I'm just going to show you just, in fact, Dr. Rohan, who operated on this patient, is sitting here. So these surgeries are done using a 38 gauge needle with the tip being about 41 gauge. And it's a direct injection, into the, under the retina once the vitrectomy is done. So that's another one done. So this amount of, so while this was reflex of air mostly, some amount of reflux is inevitable. So there's no way to not get that, but how do you sort of solve that? How do you remove that? Then becomes, what makes the difference in your surgery. So that's the overview of our phase 1. We've completed all 9 patients, and we've had no SAEs, let me not use the word major, no SAEs. And so, sorry, let me go to this. Okay, so one of the things that we have noticed is that a mild preretinal hemorrhage is almost, seen in every surgery, simply because and the retina is very thin. It's nearly impossible not to have a mild preretinal hemorrhage, but most of them resolve by the first post-op day. Just 1 out of the 9 subjects, it went on for about 2 weeks. We've had no raise in intraocular pressure. We've had no, reaction, AC reaction, vitreous reaction in the eye. So overall, we've had very, very good, safety data. So we've used fundus autofluorescence. A lot of questions about how to use this manual versus using AI generated. So these are we're still learning on the go. We have shown that in the study eye, the area of autofluorescence has reduced a bit. Although this was another one where it's reduced, but one patient did show a mild increase. So we've used the other eye as control in these patients. So in these, we also noticed that the control eye is also increasing. So the next you look at the OCTs. So one of the biggest challenges of doing OCTs in these eye is to follow a registration from before and after is very, very difficult, even with the most advanced software. Even you look at Heidelberg, you use the tracking. It's still very hard to get a perfect registration pre and post surgery. But what we've seen is there are structural changes. We do notice a thickening of the outer retina. Are these cells? I have no idea. Unless I get a histopathology a few years or how many years later, I have no idea. But definitely, we are seeing structural changes. And we did see a mild worsening of the ERM in one eye, but nothing otherwise. So again, some structural changes noted in the outer retina. The BCVA, the most important. Finally, that's the one that we're most concerned. So what we did see was, in the first cohort, we have seen an overall of 10, 30, and 11-letter improvement. So this is a safety study. We didn't expect visual improvement, but this is what we found. So we found that these patients have been followed up between 6 and 8 months, and they have sustained vision improvement in those eyes. This is the cohort 2, which has shown 15, 17, and a 7-letter improvement. And these patients have been followed up for an average about 4 months now. The third cohort has just been done, and it's too soon for us to say anything. So a definite improvement in the quality of life that we see. And looking at microperimetry, while we look at microperimetry to understand where to inject, because we have an emerging board that sits and decides and uses microperimetry and so on. Otherwise, we've not found it very useful because it's a very subjective test. So in summary, we've successfully completed the phase 1 trial, no adverse events, mild preretinal hemorrhage, mild worsening. An average of 14.9 letters of improvement is what we've noted in the first 6 subjects. So we are now going to submit this to the CDACO and before we start our phase 2 trials. So that's our overview. So that's the bioincubator in Bangalore, where we are located at. It's in a beautiful part of Bangalore, and that's my team. So you see that it's a very women-centric team. Women are the ones who are doing most of the work, on the ground. So thank you. I invite you all to Bangalore, if you are ever in that part of town. So please do come and visit us. Thank you so much. I'm sorry, I did overstep the time. I realized. I'm sorry for that.
No, don't worry about it. That was really exciting. And that's coming from a cornea specialist. So I'll probably need some retina folks in the room to start some questions. Dr. Rohan Chawla, you're the one person that...
He's been also part of the, yeah. So he'll give the first-hand experience of how it was to actually...
Please,
Oh, in fact,
tell
Dr.
us.
Shaurya. So both of them are part of the, yeah.
It's been my privilege to be part of this, and I'm really proud that for the first time in India, someone is doing such great work, basic science work, and we have been able to make these iPSCs in India itself. And we are the last end of the chain. We are just injecting them subretinal. But you saw the entire graph, so a lot of hard work done by them. Kudos to them.
Thank you.
Sure,
Thank you.
but
Yeah.
tell us a little bit more, Dr. Rohan. How does this compare to the existing very few therapies, the newer ones for geographic atrophy?
Yeah, so the complement-based injections, we have actually do not have much experience. They're not yet available in India. But from what I hear and what I have seen, well, the monthly injection is a little difficult protocol to follow. And for such a long time for the patients to persist and probably go on through it, I don't think it would be a very feasible idea for a very long term. Either they come up with an implant which slowly keeps releasing the drug, that might be helpful. So I don't think that might catch up for a very long run. So this type of therapy, which is actually a regenerative therapy, and if it works, would probably be a better option.
Fingers crossed, yeah.
So one of the challenges that at least I am aware of is, defining the outcome measures when you move
Yes.
from phase 1. So what do you think are going to be the outcome measures? Are you going to use a facility which has a street lab or something similar? Because I did see you.
We have to have a reading center, and the FDA is insistent that we show changes on the OCT. So the fundus autofluorescence that we've used here is what has been traditionally used all along, but now the FDA insists that we cannot use autofluorescence, and we also figure out that even in the areas that we inject, you don't see any autofluorescence changes. So FAF is going to be different. So probably OCT and BCVA, because finally it doesn't matter how much I show on a scan what has changed, but if it's not going to sort of reflect in the patient's vision, it won't make any sense.
Sure.
But a lot of, yes, in terms of reading center, in terms of, so now for a phase 2, we're going to have 30 patients. So that's going to be a randomized trial. So the trouble with a randomized trial is, what are you going to do with the control? What do you do with the sham? I can't go to an ethics committee and say, I'm going to inject BSS into the eye or subretinally for a sham control. But a sham is mandatory. The FDA insists that we do so we've had 2 pre-INDs with the FDA. So they insist now that you have to have a sham surgery.
Sure.
So
And my last question, what do you think is the role of, if any, adaptive imaging or optics in terms of, instead of using OCT to look at functional imaging?
So we're trying on few patients. It's not very easy to capture images when the patient cannot fixate well. So it's not easy, but from the edge of the lesion, wherever the fixation is there. So Dr. Rajni has done few in our patients, and she's going to analyze it.
No, so one of the challenges with adaptive optics is it's even harder to look at the registration. To do it before and after the same spot is nearly impossible with adaptive optics as we have today. I'm sure it's going to improve. So if OCT itself is a challenge, doing an adaptive optics imaging is going to be even bigger challenge. Probably, Rajiv has ideas about these also, because can we use an AI tool to look at all of this? These are questions that are open. I don't think any of us have perfect answers for that.
Thank you so much. Thank you. All right. That's really encouraging. All right, so let's move on to the next speaker, Dr. Shaurya Azad. He's going to tell us about hypersonic vitrectomy and recent advances in VR surgery.
A very good afternoon to all of you. So I'll be speaking on recent advances in VR surgery, and I have no financial disclosures. However, during the course of my talk, I will be speaking about some cutting-edge technologies from different companies. However, don't intend to have any support for them. So at first, I would like to take you to the past from where we actually started. So Robert McAmar was the first person to do an intraocular vitrectomy, and he achieved this with an instrument which he had developed himself, which is called the whisk, which had the vitrectomy and the infusion and the suction and the cutter, and all was put into a large bore instrument because it was a single port vitrectomy. And as you can see, it's quite big, and it had a very modest cut rate of about cut per minute. And when we go intraocular, you can see that even the father of vitreous surgery is having some amount of struggle. And moving on over here to the present scenario, we are having minimally invasive surgery with smaller instruments, good illumination, good visualization, adjunctive adjuncts in surgery which are actually helping us do the surgery, and laser, which is state of art, which is very well reproducible, and suddenly you end up doing a very good surgery, and even an average surgeon like me starts looking good. So what all has changed? What has actually led to something like this? Well, we'll be talking about it. So the vitrectomy machines, as I said, that initially what happened is that we had this instrument which is called the whisk, and at that point of time it was a single port vitrectomy, and thereafter they realized that it is better to have 3 access points, and they proposed a 3-port vitrectomy, and that is when the infusion and the cutter and the illumination all found their different routes of going inside. And then there was different machines for all of these. So in the present scenario, what we have is all these machines. I don't have any particular interest in any one of them. There are many more as well. However, these are the common ones. So these machines have all-in-one console in which you have a laser, you have a vitrectomy machine, and also an illumination. And all of these, still better, in 2025, are going to launch their newer models, which they claim to be having better fluidics, better IOP control, and state-of-the-art laser, like the Alcon is proposing that they'll have a tetra port in which you have a multi-spot laser for an endo laser. So the things are looking better. With respect to visualization, we've had 3D vitrectomy, in which we have this Ingenuity system and also the RTO that is there, in which we can simply look at the the big LED screen and wear Polaroid glasses and have a in-depth a 3D perception of your surgery, which aids in the precision of our surgery. And if you can see, simply the ergonomics are also better, as they say, although I don't feel, but you can have very less illumination if you can just focus on the 59% light, which is almost half of what we use normally, and it is less phototoxic. It can provide good magnification, as well as that it can be a very good teaching tool for all the others who are looking. We also have the microscope, which has got an OCT integrated into it. Now you can simply do the surgery, and if you're seeing an ERM, you can actually focus it on the retina and simply then peel it, go back and confirm it that you've removed it, and then again you can go back and peel the ILM, and you can do the same. It is also finding some amount of application in subretinal injections, as we just saw one presentation by Rajini ma'am. Instrumentation has also become much and much finer, like the cutters have actually become much slimmer, and although they have become slimmer, they are still rigid enough to actually withstand the trauma of the surgery and let us achieve good outcomes. The ports have become closer to the retina, and these ports easily help us in delamination and segmentation. The beveled ports bring the port to the retina closer still, and again helping us in our surgery. The cutting technology, what it was before, was what we had this, which was a single pneumatic cutter with a spring recoil. So the air pressure actually puts it to cut, and the spring recoil actually brings it back. And because of which we had 2,500 cut rates, now we have a dual pneumatic cutter in which you have the air pressure pushing it forward and the air pressure bringing it back, and that is why we have got good cut rates, and that makes our vitrectomy even more and more stable and more precise. Again, initially we had one-way cutting in which we could only cut while going forward. We were not cutting while coming back, and it was limiting the cuts per minute. And then you suddenly go on to have such a bi-needle configuration which you cut going forward and backward as well, and thus suddenly an 8,000 cut rate becomes a 16,000. The same ways Alcon also has this hyperwidth cutter in which you have a similar sort of a efficiency in which you have a dual pneumatic valve again for to and fro, as well as you have a cutter which is cutting both the sides going forward and coming back, and the bevel actually helps us simply just going and as close to the retina, finding these planes and segmenting it and cutting them. So if you can see even the stability of the chamber, if you see in a 20 cut, the flutter that is there of the vitreous, or for that matter even the retina, is much lesser in comparison to the 10K, and thus it makes our surgery much more predictable and less traumatic. Moving on to hypersonic vitrectomy, well, this was a propriety of the Bausch and Lomb, in which they have this handpiece which has got a transducer which gives this ultrasonic shock waves which dissipates from the edge of the needle, and this then emulsifies the vitreous that is surrounding it, and there is a port right at the center which then just sort of aspirates the emulsified vitreous. And so the port is always open, so in a way the duty cycle is almost 100%, and there is very less traction. However, there are some concerns regarding it because it dissipates some amount of thermal energy, and that can lead to some bleeding or even burns, as well as sometimes it doesn't actually give that much of emulsification as is required, and there must be some strands that are left. As you can see over here, the traditional cutter is basically just pulling, and there is some shearing that is there, whereas in the hypersonic, if it does its job well, then it just kind of aspirates. Trocar cannulas have become much better. You have valve cannulas, which are actually a big boon for diabetic vitrectomies because the chamber is closed and very less chances of bleeding, and even the cannula systems have become such that even a larger gauges kind of make smaller incisions so that the healing is better, and some of these cannulas can also be illuminated, which can be a boon for us because we generally operate in dark rooms, and finding our way inside the eye becomes much easier. Illumination, again, we have gone from mercury vapor to xenon to now LED, which is much more safer. There are modifications of these laser probes which might be shielded, which do not shine into your eye. They might be focused, they might be wide angled. They can be also chandeliers which are there, which actually help us in doing bimanual surgeries. So there are a lot of modifications that are there. Forceps, again, these are few like the shark skin forceps, which are basically a laser ablated edges which kind of cause some amount of traction, which is easier to peel the membranes, as well as this finis loop, which is sort of a replacement of a DDMS, in which you can simply scrape it over the ILM to lift a flap. And then these are these forceps, which are basically 3D forceps, which are made specifically for the surgeons having a particular grip. Lasers, again, have bidirectional laser probes are there, which can become straight when you're away from the retina. If you're accessing anterior of the retina, they are curved. So they you can have those. You can have illuminated for laser probes, which can actually help us to do, again, sort of a bimanual surgery by indenting from outside and then trying to laser these anterior parts of the eye. And then finally, which is probably exciting for me at least, that if we have a multi-spot laser as an endo laser, that makes our time much more quicker. And then you have these subretinal injections, which are actually going through an automated sort of a syringe in which we can actually, control the pressure of these syringes. And the injection that we were actually putting in the stem cell is actually through these, syringes, and so that we can put it through a very controlled manner and it doesn't find its way outside from somewhere else. Future, well, as everyone's talking about AI, if you can integrate all these things, OCTs and, the angiography and everything into the, the machine that you have, vitrectomy machine, and then if it can kind of generate something to how to go about the case for the best outcomes, that can probably be the case. Or maybe a robotic surgery in which it is either an operation assisted system or maybe a tele-robotic surgery in which a person is actually somewhere else and is doing the surgery with the help of a robot that is there, maybe the future. Thank you.
That was really nice. Thank you. Any questions from the audience? Any comments? Dr. Azad, I have a naive question. I saw the cut rate has been going up, and I can tell you, Dr. Rohan was my teacher when I was back in RP Center as a resident. Things have improved significantly, and I witnessed that when I work with the retina colleagues when we do combo cases. Is faster really better or safer compared to what we have right now?
So it's something that I didn't believe in until I just used a 20K. So basically what happens is that as the more the cut rate is, your vacuum becomes less and less effective. So we keep on increasing our vacuum. So we got used to using 25 gauge at a higher vacuum of 400, 500. But with these dual cut and this hyper width that is there, we don't have to keep that vacuum at that level, and we can achieve it at the levels which were there probably even during our 20 gauge, because the port is open that much more time than what it was open in the traditional, the conventional ones. So yes, if you have the vacuum going in line with your cut rate, then probably it makes sense. Else, just about going to a higher cut rate and increasing a vacuum probably may not be that helpful.
Okay. Well, thanks so much for explaining that. Any other questions? Thank you. Let me invite the next speaker, Dr. Rajiv Raman. He's going to talk about predictive systemic health analytics from retinal images. Thank you.
Thanks. It's a real pleasure being here. And next few minutes, I'll be talking on some predictive systemic health analytics using retinal images. So this was a slide John had shared very recently, his article, where he talks about, that's oculomics, that from retinal images you can take out, you can get information about many other systemic diseases. Probably one of the only organ where microvasculature and nerves can be visualized and imaged. And retinal photograph people have been trying to use for analysis of microvascular changes, diagnosing predictive events for systemic vascular events, and OCT probably looking at retinal layer thicknesses, the various individual segmented layers, trying to diagnose neurodegenerative diseases. I'll share some of the work which my team has been doing regarding systemic diseases. So this was actually a couple of years back where we thought, can we use the retinal images to diagnose diabetic neuropathy? And we did publish this research a couple of years before. There are no discernible structural changes in the retina. However, there are functional changes, retinal sensitivity changes, which are seen with diabetic neuropathy. And we thought that can we use the predictive power of deep learning to detect neuropathy from retinal images. And this was a work we did with Cambridge consultants, and we used our population-based data set called as Ascend Dreams, where we had the neuropathy data along with the retinal images, and we used that data set for training and testing the algorithm. This was the algorithm, and when we trained it on the data with no diabetic retinopathy, we could get a pretty good accuracies to detect neuropathy. And in presence of diabetic retinopathy, it was even better detection of diabetic neuropathy. So we demonstrated for the first time that using the retinal image, we can identify people with diabetic neuropathy. Now that's important in our country where the foot ulcer rate is pretty high and a lot of people undergo amputation for it. If we can do a simultaneous screening of diabetic retinopathy and neuropathy, it extends a possibility of preventing other microvascular complications. The other work which my team has been working is on, can we predict anemia? And this is not new. There are already attempts people have done. And we wanted to use the same data set, people with diabetes, because we know diabetic nephropathy causing anemia, and that's something these people have very common problem. And we tried developing a deep learning model which could detect the anemia levels, the hemoglobin levels using a retinal image. This was very recently, last month, published in TVST. We got good accuracies to detect anemia, even the level of hemoglobin we could find out using these images. We went ahead looking at explainability, where the AI looked into, and then probably doing in that area a more detailed analysis, what exactly AI looked into, and it seems to be it's the vessel density, tortuosity, and the vessel thicknesses in the peripapillary area, which probably may be a marker for anemia. The next work which we are now doing is, can we predict intracranial pressure using retinal images? And the thought came because there are now changes, structural OCT changes, which can happen with increase in the intracranial pressure. This was a recent publication, and based on these things, we started looking at our patient database of people who had a OCT a week before they underwent a lumbar puncture, where the opening pressure was determined. We again used the deep learning model and could very well determine a binary classification of raised or a normal intracranial pressure using OCT images. So we demonstrated again that using OCT images, deep learning, we can non-invasively classify intracranial pressure. It seems to be a good method, but needs definitely more validation to confirm. The other work which has been, my team has been doing is, can we predict mortality, the retinal age gap? And there has been a lot of work on this. The retinal age is the age determined from the AI algorithms, and there's a biological age. The more difference between these two is it is proven to be a risk for mortality. We used it on patients with diabetes, and we did find we could identify the retinal age with a pretty good accuracy. And then we also found that with increasing retinal age, there's also, it's an independent risk factor for diabetic retinopathy, more so for proliferative retinopathy, and those who had a greater age, the retinal age, more than, they had twice the odds of mortality. We had this longitudinal data. So this is something which is coming up new, algorithm which can predict the, as one of the risk factor for proliferative disease and even mortality. So eyes are window to soul, that's what we all know, but definitely it seems it's not only soul but also our health. I'd like to thank my research team for helping me do these work. Thank you very much. I'd like to invite all of you for the APOTS Retina meeting, which we are having in July.
Thank you, Dr. Ajit. That was really insightful. Any questions from the audience? Any experiences that somebody wants to share? Dr. Ajit, how do you see this being integrated into clinical practice?
That's a challenge. John also told Ophthalmics that's a major challenge. We had this neuropathy and even nephropathy, they are pretty good who can detect CKDs. If you ask a nephrologist, he says, I don't need a retinal image to diagnose CKD. I have my other tools. So that's a challenge. Even regulatory approvals would be a challenge in this, as exactly Dr. John said. But there is a great potential, like some of them which are non-invasive, like a lumbar puncture, you can avoid doing that, needs more validation, but these are the things which can definitely help change. Or simultaneously screening for retinopathy and neuropathy, they have got a great potential.
I mean, I agree that that's one of the biggest challenges, and with the increasing prevalence of diabetes worldwide, I think this is still a very important body of work that will hopefully serve its purpose over the next few years, maybe less than 10 or something. I agree with your comment on diabetic nephropathy, as medical students, at least I was taught back in India here, homeland, where when an endocrinologist or a nephrologist diagnoses a patient with diabetic nephropathy, it is a given that they will have some retinopathy as well.
Yeah.
And if you go back to the basics, we all know that the size of the vessels, the back of the eye, it matches the size of what we see in the renal system. So if you see a patient with diabetic nephropathy, a good endocrinologist or a GP or a PCP, depending on where you work or practice, they're going to send the patient back to an ophthalmologist for screening of diabetic.
Recently, I was in a meeting where nephrologists were there, and there's a big problem diagnosing CKD, whether it is because of hypertension and diabetes. And one of the factors they take into account is retinopathy. They say if there is diabetic retinopathy, it's a diabetic kidney disease. It's not a hypertensive. So definitely it has a role, but probably just looking at a retinal image and telling the stage of CKD, the nephrologists are not comfortable.
I still remember the term I learned back in RP Center, renal retinopathy. I don't know whether cells still used there or
Not used now.
Yeah.
Yes.
But we still have hope if the nephrology team is with you. Any other questions before we finish this session about half an hour earlier? I don't think Dr. Radhika is here. All right.
So, Rajiv, you said about the mortality. Want to tell me a little, so what happened? How long did you actually follow?
So these are the patients who, so there are two cohorts. So we had the initial cohort, we followed them after 4 years, and we had these images of, so when we went back, there were about 200 patients who died. So we had that retinal image before, so we used that image to predict the mortality. We had 4-year thing. A subset of them, about 100 of them, we have a 16-year follow-up. But definitely that's, so this is being recognized now that retinal age, which we detect from by using AI, and the biological age, if there is a big difference between that, that risk of mortality is high. I actually, in this diabetic cohort, I was more interested that this seems to be an independent risk factor for proliferative diabetic retinopathy. I think that becomes important.
But what is retinal age? So, have you done it also in patients who are people who are non-diabetics?
We have not done, but there are papers which are published on non-diabetic cohorts. I used my diabetic cohort to do this study.
Yes, please.
There's one question I have. It's more a generic question. So when we start looking at the fundus of patients with a whole lot of systemic diseases, we'll pick up a lot of features. How do we sort of make the differentiation between causation and correlation?
So this you are talking about clinically or using AI?
Using AI.
Yeah, so
We might find so many features that say is there in the retina of a person who has CKD. But what is really those linkages that will predict, which could be used as a screening or which are actually
again,
meaningful?
your study question is designed before. So like the anemia, we labeled those images using their hemoglobin values. So you don't just look into that whatever features are seen and then come out that what you are looking. So we were trying to see, can my retinal image predict anemia? So we used those images and labeled it with the corresponding hemoglobin values, and then saw that can my AI algorithm predict those hemoglobin values with accuracy, which we could do it. So whatever, like OCT, we knew that there is a little displacement of Brooks membrane whenever there is a raised intracranial pressure. Many times we cannot make out that displacement, how much it is happening. So we were lucky to have this data set of people who had a lumbar puncture opening pressure. Within a week before, they had a OCT. So we used those opening pressures to label the OCT and then tried looking at can we predict the intracranial pressure. That's what was asked, the predictive. So this is what the predictive things are.
Yeah, I have a questions for you. As I have seen, like a lot of CNN, like convolutional neural network for the statics image processing. So do you see any chance or opportunities that we could use like more complex model for the real-time diagnostics or prognosis in ophthalmology?
Definitely, now it's not only CNNs, we definitely have many other models like transfer learning or hybrid models. in real time, how it will be implemented is something could be a challenge. In research studies, they are done pretty good. But yes, I'm sure these things will become more simpler. The way AI is progressing is much better than the problems we are giving to it.
Thank you.
All right, any other questions? Well, I want to thank all the speakers and attendees for the wonderful session. So we're closing the session with this talk. Thank you so much, everyone.